Good morning, Board of Directors. This is Brittany Farmer, your Compliance Officer, and today I'd like to meet to talk to you about our patients' moral right to care and our facility's ethical responsibility in providing that care. In a healthcare organization, it is important to understand and practice ethical awareness and differences as well as commonalities. This presentation will brief possible concerns, procedures, and processes for dealing with ethical concerns while maintaining the morality of the organization. Our objective is to understand increased ethical awareness and our moral responsibility to provide high-quality health care to all. We have and will continue to encounter situations in which we must make an ethical decision to provide care regardless of a patient's ability to pay or other extenuating circumstances. We will discuss some of the common encounters in the following slides. The items include code of conduct, patient rights, informed consent, genetics discrimination, patient safety, medical malpractice, and cultural competency. A healthcare organization must also organize internal structures to address medical and administrative ethical issues and concerns. In addition to establishing a code of ethics and conduct, officials such as compliance officers, risk management officers, and offices of general counsel provide a broad range of oversight. Working alongside these officials are institutional committees such as aesthetic committees and review boards. This checks and balance system helps our organization maintain an unbiased moral compass at all times. This also helps us to identify how to treat our patients and what they are entitled to. More specifically, the Patient Bill of Rights outlines in detail those guidelines. The Patient Bill of Rights was created to try to reach three major goals. First goal being to help patients feel more confident in the U.S. healthcare system. The second goal is to stress the importance of a strong relationship between the patients and their healthcare providers. And thirdly, to stress the key role patients play in staying healthy by laying out rights and responsibilities for all patients and healthcare providers. On March 23, 2010, President Obama signed the Affordable Care Act into law. 6 months later, Critical Consumer Protection, a Patient Bill of Rights, takes effect. The Patient Bill of Rights puts an end to some of the worst insurance abuses and puts consumers, not insurance companies, in control of their health care again. Changes included bans on discrimination against kids with pre-existing conditions, insurance companies dropping coverage, bans on insurance companies limiting choice of doctors, insurance companies restricting emergency room care, the guarantee and right to appeal, covering young adults on parents' plans, and covering preventive care with no cost. We can't speak about the morality of care without addressing informed consent. The underpinnings of informed consent originate from the legal and ethical right the patient has to direct what happens to them and from the ethical duty of the physician to actively involve patients in their health care. The 5 basic requirements include disclosure of information, decisional capacity, patient's comprehension of information, voluntariness, and consent of the patient, help protect the organization as well as the patient when undergoing a medical procedure. It is imperative that the medical organization and the patient work hand in hand to develop a plan and decide what treatment works best for the client. Furthermore, our organization will take all measures to protect against genetic discrimination. GINA, which is the Genetic Information Non-Discrimination Act of 2008, prohibits the use of a person's genetic information for purposes of health insurance and employment. GINA protects insurers by making it unlawful to require genetic testing for coverage and basing premiums on genetic information. It also prohibits the collection of genetic information as well as protect the client's privacy. Congress concluded 5 findings which were the premise of the current genome law. The first finding, due to advances in genetic marking and ability to identify illness prior to symptoms, genetic information could be misused. Prior history of sterilization in people who are carriers of genetic defects required immediate attention due to new advances in genetic science. Thirdly, prevention of discrimination to race or ethnic groups known to carry certain genetic markers would be prohibited. Discrimination in the workplace or hiring techniques based on genetic information would be prohibited as well. To provide a uniform and federal standard in the use of genetic information obtained, allowing clients to test freely and prevent the use of this information in discriminatory health insurance practices. In addition to protecting privacy and a right to care, safety has and will remain a top concern for our organization. The Patient Safety and Quality Improvement Act signifies the federal government's commitment to fostering a culture of patient safety. It creates patient safety organizations, PSOs, to collect, aggregate, and analyze confidential information reported by healthcare providers. Additionally, the Act specifies the roles of PSOs and defines patient safety work product and patient safety evaluation systems, which focus on how patient safety event information is collected, developed, analyzed, and maintained. In addition, the Act has specific requirements for PSOs, such as where they are required to work and how many providers. Eligible organizations include public or private entities, profit or not-for-profit entities, provider entities such as hospital chains, and other entities that establish special components. Ineligible organizations include insurance companies or their affiliates. Finally, the Act calls for the establishment of a network of patient safety databases to provide an interactive, evidence-based management resource for providers, PSOs, and other entities. It will be used to analyze national and regional statistics, including trends and patterns of patient safety events. Now, we are always at risk for medical malpractice, but we will take responsible care of our patients and our trust to prevent mistakes that could lead to such accusations. Ordinarily, there is no viable claim of recklessness or willful misconduct. Instead, almost all professional malpractice cases are predicted on the theory of negligence or unintentional deviation from the standard of care owed to the patient. Thus, the awarding of punitive damages, which are intended to punish the wrongdoer for intentional or reckless and wanton conduct, is exceedingly rare in the malpractice context. We have to talk about vicarious liability. It's the principle that an organization that has an employer-employee relationship or a supervisor-supervisee relationship with another is ultimately liable for the negligent acts and omissions of the employee or supervisee. Under vicarious liability, an employee or a superior is liable regardless of whether he or she was personally or directly at fault. Guidelines like these are important not only as public statements of minimal thresholds of quality, safety, and ethical care, but also because they help inform the thresholds for legal negligence and in malpractice or professional liability contexts. Failure to comply with the professional standards and guidelines for safety practice may stand as compelling evidence of a healthcare professional or healthcare organization's breach of duty. This is why we are increasing our training to quarterly vice biannual training. Our organizational legal team will review all new contracts to ensure there are no connections to our facility and its employees. The purpose of that is to try and prevent any accusations of Stark's Law violations. The Stark Law provides a nearly complete ban on any Medicare or Medicaid payments for services falling under the statute in which the referring physician has a close personal financial stake. It has been postulated that the aforementioned types of arrangements became prevalent in the 1980s as a result of the restructuring of payment systems in the healthcare industry aimed at cost containment, with many citing the advent of the Medicare program's prospective payment system. Concept of culture. So, understanding other cultures is critical to effective care in our organization. We must morally treat our patients with respect to their cultural wishes and expectations. A common goal of any medical professional is to create an inclusive system that allows staff members to work at a maximum productive level, as well as provide culturally competent health care. These better working relationships will yield greater mutual benefits for staff and patients alike. So, in summary, these are some of the ethical responsibilities that we have in providing patient care, and our patients' moral right to have such care given to them. We focused on our code of ethics, patient rights, informed consent, genetic discrimination, patient safety, medical malpractice, and cultural competency. Thank you for your time, and I hope that this presentation has helped shed some light on what our responsibilities are within our facility and how we will continue to improve upon such.